think we're live.
Yeah, I do too, but I don't see.
There we are.
Okay.
All right.
There we are.
Oh,
Hello, everybody. My name is Kyle King, and welcome to the IOCDF Research Roundtable, the live stream where we pick an interesting topic within the OCD literature and discuss it with people who know it better than at least I do. I won't speak for you, John.
Definitely better than me too.
Fair enough.
Especially today.
Yeah, well, I'll discuss kind of what we're going to be talking about today a little bit later. But before we get to that, as I said, I'm Kyle King. I am an IOCDF advocate. I'm a person who lives with OCD. And as of last week, I'm a medical student now, which is really exciting. We started the stream when I was a sophomore in college. And if you've been watching this stream throughout its tenure, you've seen me talk about the MCAT and the application process. And get increasingly anxious. And now I've started medical school and I'm going to be anxious for the next 4 years. So that's fun. As always, I'm joined by my co-host, Jon Abramowitz. Jon, if you want to say a word about yourself.
Sure. I'm Jon Abramowitz. I'm a professor at the University of North Carolina, and I spend my career doing research on OCD and other related problems. How do we treat these problems and understanding, where do they come from and various aspects of OCD, including cognitive biases, which is why I am very excited for today's live stream.
Yeah. So as Jon just mentioned, we're going to be talking about cognitive biases today, which I was kind of reflecting on the past couple streams. And I feel like for a while now, Jon, you and I have been on a run of doing like OCD and X, and that X being some other mental disorder. And today I was looking forward to kind of thinking kind of past particular diagnoses and getting to the root cognitive things that underlie these diagnoses and cut across a lot of the ones that we've been talking about.
Yeah. And anyone who watches the live stream knows that kind of that's my jam, right? Rather than looking at, this diagnosis and that diagnosis, understanding the cognitive and behavioral facets that kind of play into problems like OCD. So I'm really excited.
Yeah, and we do have two great guests with us today. But before I introduce our guests, I have a couple of words that I need to say. First, this live stream is educational and is not intended to replace therapy. For treatment-related questions, please work with your provider or contact a local clinician. You can use the IOCDF's online resource directory at iocdf.org/find-help to locate a trained clinician near you. Also, the International OCD Foundation is not a crisis hotline. If you're in a crisis or if you're ever feeling suicidal or unsafe, please call the 988 Suicide and Crisis Lifeline by dialing 988, or you can access this online at www.988lifeline.org, or go to your local emergency room or call 911. It's also worth mentioning that this is live, as the name live stream implies. So we have a chat function. We love when you put questions in there. We love when you put comments in there. We try to get to as many questions as we can throughout the stream. Just know that what you write in there lives on the internet forever, and we want to keep that space as kind and respectful as possible. All right. Well, now let's introduce our phenomenal guests. I'll start with the first biography that I have on my little Google Doc, which is Dr. Ryan Jacoby. Dr. Ryan Jacoby is a licensed clinical psychologist at the Center for OCD and Related Disorders at Mass Gen Hospital and is an assistant professor of psychology at Harvard Medical School. Boo, as someone who goes to Yale Medical School. Her clinical and research interests are broadly focused on the nature and treatment of OCD and anxiety disorders, including specific interests in transdiagnostic psychological mechanisms of change and exposure-based therapy, as well as the treatment augmentation strategies that capitalize on these mechanisms. Dr. Jacoby is currently funded by a Career Development Award from the National Institute of Mental Health, examining attentional cognitive control as a mechanism in the transdiagnostic treatment of repetitive negative thinking. Certainly a good person to have on the stream today. Dr. Jacoby, I was trying to think of a fun question, and this is the first one that popped into my head. It was an icebreaker question we had the other day. What's one brand that you find yourself very allegiant to?
Ooh, that's an interesting question. Thank you for asking. I don't know. I wouldn't say that I'm actually particularly allegiant to any specific brands. I guess it's not quite answering your question, but I am a runner. That's something that I love to do. So I feel like the first thing coming to mind is various, different running brands and things like that. But I'm not allegiant to any one in particular. But something that I do enjoy to do is to run.
Good enough answer. Do you run with like those Hoka shoes, I think they're called?
I do, yes, actually.
Okay. I've seen those shoes around all the time at the gym, but I don't, they seem to be very popular. I don't know why. Our other guest today is Allie Adamis. She's a third-year clinical psychology PhD student at Vanderbilt University, studying with Dr. Bomi Alatunji. I hope I got that right. Her research examines cognitive mechanisms involved in the maintenance of anxiety and related disorders, with a particular focus on attention, cognitive control, and repetitive negative thinking. Both you guys, your biographies ended on the same phrase. Allie, same question goes to you. What's a brand that you find yourself allegiant to?
The first thing that came to my mind, the first thing that came to my mind was Costco, but I guess the associated brand is Kirkland. I grew up going to Costco, but then never had a car in my adulthood until I moved to Nashville. And now that I have a car, I'm all about a big run loading up. So
I've never been a big Costco person. I should probably switch over though.
Is there a particular reason?
There's just not one near my house wherever I live.
Yeah.
Where are you from?
Fun experience. I'm originally from Boston. I lived the longest in Northern California. But in my adult life, living in Boston, there's no need for a car. So
Ryan knows that too.
Yes.
All right. Well, thank you for entertaining my silly questions. Let's hop into kind of the meat of what we're going to be talking about today. We said it was going to be cognitive biases, but we haven't even defined that term. So what is a cognitive bias? I feel like it's a good place to start. And anyone can take any question.
I can take a stab to start. The way I think about cognitive biases is a particular pattern of thinking. And that can take the form of a particular set of beliefs that you hold, or a particular way of information processing. So information processing, we usually think about things like attention and memory. So particular patterns in the way that you're paying attention to, thinking about, and remembering things.
Yeah, I think I totally agree with that definition. I think in terms of specific cognitive biases, maybe I'm jumping the gun a little bit, but in terms of specific cognitive biases that we often kind of think about in the context of OCD. So intolerance of uncertainty is one that I've done a lot of research on. And so certainly one that we see in OCD and other anxiety disorders, which is essentially the kind of perceived inability to manage uncertainty and ambiguity in one's day-to-day life. So this could either look like being paralyzed by uncertainty, getting kind of frozen, or it could look like needing to get increased information in order to feel certain about a specific topic. So that's one cognitive bias that we often see. Another cognitive bias that we think about in OCD is perfectionism. So feeling like you need to do everything just a certain way, or kind of doing something perfectly. We also see responsibility for harm, which comes up a lot when folks are concerned about, doing the right thing, being able to, taking on responsibility for other people and their harm. And so I'm sure I'm missing one. Importance and need to control thoughts is the other one that we often see in OCD. So this can come up a lot with unacceptable thoughts. So where individuals feel like if I have an unwanted thought, for example, about, stabbing a loved one with a knife, that's a totally inappropriate thought to have. I shouldn't have thoughts like that. That means that I'm a murderer and, shouldn't be around knives, shouldn't be around people. And so I need to control thoughts like that. So those are some examples, I guess, of cognitive biases that we see in OCD.
And just to add to that, I think it's important to differentiate between cognitive biases and cognitive deficits, right? So a bias is a mistake in our thinking. It's a tendency to make a certain mistake, like the tendency to overestimate threat, right? If there's a chance that something bad might happen, a person with a cognitive bias might overestimate that. Oh, it's probably going to turn out badly. Whereas someone without that cognitive deficit, they're just kind of, the way they think is, oh, it's probably going to be okay, right? And that's different from a deficit, where like maybe something's broken. There's been like some sort of trauma to the brain or something like that, and there's been an injury, and they can't process certain information. And I guess a good analogy, a good metaphor for that is with a computer. If you think about a cognitive bias, it's more like a software bug, as opposed to a problem with the hardware, like the motherboard is broken. That would be more like a cognitive deficit. Maybe we can talk more about that later on.
I do have a list of questions that try to get parse those out, because it was a little bit confusing to me when I was reading things. But so these cognitive biases, are there's something that everyone has, everyone is they have cognitive biases, and then folks with OCD or maybe other mental disorders have them to a greater extent? Or could you elaborate on that?
Yeah, I'm happy to start with this one. I would agree with that statement. I mean, maybe just using one cognitive bias as an example. So intolerance of uncertainty, most of us don't like uncertainty, but we dislike it to varying degrees. So to give an example, let's say that you suddenly are surprised and you're going on a surprise vacation with a partner, and you're like, oh my God, I don't even know where we're flying to. That might be exciting. So sometimes uncertainty can be something that people enjoy, but for the most part, let's say that, for example, you just took an exam and you're uncertain about your grade on the exam, regardless of whether you have OCD or not, you're not going to enjoy that type of uncertainty. So I think for the most part, where people with OCD can differ from those without OCD is how they sort of interpret, in this case, I'll stick with the example of uncertainty. So one person maybe who has this exam coming up, and maybe they struggle with intolerance of uncertainty, perfectionism, things like that. And they might, for example, think that I can't tolerate not knowing for sure what my grade is on this exam. Whereas those of us without OCD or anxiety disorders might be able to say all right, I don't love the fact that I haven't gotten this grade back, but I can sit with it. I can manage it, and can kind of take on that day-to-day level of managing uncertainty.
And when we study these things, I guess, to me, it's kind of, there's a video game analogy where you can turn the sliders up on a particular character. Mm-hmm. Is it kind of like thinking about each one of these cognitive biases on a spectrum, and someone with OCD has all the sliders turned all the way up, or different combinations of sliders turned all the way up? Yeah. How do you conceptualize OCD when there's all these different cognitive biases that can go into making a disorder, I guess? Or is that even the right way to ask a question?
I like that analogy, and I think that's a pretty good way of thinking about it. And it's important to think about the fact that even within the group of OCD, there's variability in where you lie on that spectrum. So it's kind of the unique combination of your settings of those various cognitive biases that might contribute to a particular manifestation of OCD. So some of the cognitive biases that we're talking about are more or less associated with certain subtypes of OCD, responsibility for harm is more associated with the unacceptable taboo thoughts or harm-related OCD. So there's variability in terms of different subtypes, and even just from individual to individual within those subtypes.
And I think, just to add to that, the cognitive biases that we see in OCD are not necessarily specific to OCD. Mm-hmm. That tendency to overestimate threat, the tendency that Ryan was talking about to have difficulty with uncertainty, those are things that we might observe in different problems with anxiety, and even in things like depression and eating disorders and things like that, research shows.
Are there any biases that are specific to OCD? There's questions popped into my head.
It's a good question. Yeah, I think, I don't know what you guys, Allie and Ryan think. I don't think there's a lot of evidence that there are specific ones that this only comes up in OCD, or that this is like a almost like a diagnostic proxy. If you have this cognitive bias, you definitely will have OCD. I don't think we have that.
Mm-hmm.
Yeah, the one that I think, this is not based on, any research study per se, but just clinical experience. The one that I guess I haven't touched on when I was mentioning different cognitive kind of cognitive biases that can come up sometimes, more so in OCD than in other anxiety disorders that I've seen, is the kind of the not just right beliefs, like I need to have something be just right. That sometimes it seems like it's more unique to OCD. I haven't really seen that much in other anxiety disorders.
So like when you say not just right as a cognitive bias, I've always thought of that as like I guess subtype or symptom. So like what's the distinction there?
Yeah, I guess that's a good question. So I guess I see the kind of bias as being, I need to have kind of like that perfectionism certainty. I need to have everything just right a certain way. So you're right. I think usually when we say NJRE or not just right experience, it is more of like a symptom subtype.
Okay.
Well, yeah, and that just like we can see a need for certainty. Some people have that. Yeah, I mean, right. I guess it's a good question. Is that a symptom? Is that a cognitive bias? That need for, I guess completeness. I don't know what you might call it. Yeah.
Right.
Yeah, these things get hazy pretty quickly. And Tom also in the chat is mentioning some other cognitive biases. Yeah. It was really interesting when I was like reading a little bit beforehand, how you can kind of enumerate which ones pop up a lot. And I wrote a list of some, and you've mentioned some already. But I kind of want to go through them and like kind of explore the evidence that they are unique to OCD, or like to what extent they play a role in maybe the condition. So you mentioned intolerance of uncertainty. Like, how do we go about measuring the extent to which intolerance and uncertainty is meaningful in OCD? And like, what is the evidence that people with OCD tend to have more intolerance of uncertainty?
Yeah. So I think with intolerance of uncertainty, typically like the gold standard way of measuring it would be like with a self-report questionnaire. So a series of items that you, on a measure that you give to someone to fill out, and, asking questions that, this isn't going to be verbatim, but things like, how well are you able to cope with things that are uncertain, or statements like, I need to know everything for sure. And people sort of endorse, how much they believe those things. One thing that I've been really interested in, though, is trying to move beyond self-report measures with intolerance of uncertainty in my research. So trying to develop even kind of in laboratory behavioral tasks in which there's a task that's, ambiguous, and kind of measuring things like distress or pieces of information people request before feeling certain. Because I do think, just asking someone to report on their beliefs about uncertainty doesn't always capture the full picture. And sometimes it can be helpful to actually see how people feel and perform in actual uncertain or ambiguous situations.
Mm-hmm. Yeah. Do you have anything you want to add?
Just in terms of the kind of other end of the question that you asked, like what do we know about it related to OCD? So like we've mentioned before, we see an association between OCD and elevated levels of intolerance of uncertainty. It's mostly studied using those self-report questionnaires, but sounds like there's increasingly research using more behavioral paradigms, which is awesome. And within that, there's also evidence to show that like inducing uncertainty, so putting those folks in situations where it is more ambiguous, we tend to see more distress, more of an urge to resolve the uncertainty, more repetitive negative thinking, things of that nature. So it does seem like it's a correlate of the disorder, and it also is probably playing a role actively in the maintenance of the disorder.
Okay. And then kind of the same line of questioning, like how do we measure it, and what's kind of the correlation between OCD and the inflated importance and the need to control thoughts that I think Allie mentioned earlier? And what is that cognitive bias? Just if we could elaborate it a little.
So the overimportance of thoughts and the need to control.
Mm-hmm.
Yeah. So generally that's referring to the sense that my having a thought is more meaningful than just having a thought. So maybe it means that thing I'm thinking about is more likely to happen, or it reflects on who I am as a person. So if I have a thought about harming someone or doing something immoral, that means I'm a bad person. And so those kind of thoughts need to be controlled or neutralized, or I need to do something to prevent the bad outcome that I'm thinking about. So again, things like that, we tend to study using self-report questionnaires where folks endorse items about the extent to which they believe those things. And there's a pretty clear signal that that's a elevated importance of thoughts, and this need to control your thoughts is associated with OCD, which totally makes sense, because if you feel that way and you have an intrusive thought or a really repugnant image come into your mind and you think that really means something, of course, that will lead you to engage in actions to address that, which could look like compulsions.
At 1216, Tom W. Mentioned thought action fusion, which I think is another term for Allie, what you're describing. And in addition to questionnaires and self-report, there are also some interesting experimental studies where you bring folks into a lab and you ask them to think about like the person they love the most in the world, right? So I might think about, my wife, for example. And then they give you, we've done a couple of studies like this in our lab. They give you a piece of paper and it says, I want blank to die today. And your job as the person in the experiment is to write that sentence and fill in the name. So my wife's name is Stacy. So I'd have to write, I want Stacy to die today, right? And people are going to have different reactions to doing that. Some people are going to be like, fine, whatever. I'm just writing. It's, pencil on a paper, not a big deal. Mm-hmm. And other people are like, I can't write that. That means something bad is going to happen. So you would ask the person, why are you afraid to write it? How anxious are you to write that? What if it really happens? And that's an interesting experimental way to measure, your beliefs about thoughts and the power of thoughts. And it turns out that folks who have higher certain types of OCD symptoms have more trouble with a task like that.
Mm-hmm.
Two things come to mind. First, are there physiological signs? Like if you measure skin conductance, are they a little sweatier in people with OCD than in controls?
Yes.
Okay. And then I guess, is it the case that someone with contamination OCD may not?
Right.
Right. Okay.
That's right. And that's why, when we talk about OCD, we're talking about a dimensional problem, right? The folks with washing and contamination concerns, their sets of cognitive biases might be really different from folks who have the kind of unwanted taboo thoughts about harm or sex or blasphemy or something like that. And folks that worry about disgust, right? That might be different. And the folks that worry about not just right and completeness, that might be different. So, and that's, I think, one of the interesting things about OCD. We tend to lump these different symptom types together because they all involve some sort of obsessional thinking and compulsive behavior. But if you look at it from the lens of cognitive biases like we are today, these things are actually really different. And that plays into different approaches, maybe to treatment and to understanding the problems.
Yeah. So are there cognitive biases that tend to cluster around certain subtypes? Like, since now we've kind of broken up OCD into the dimensions that it has, is there evidence to suggest if you're dealing with contamination OCD, maybe these cognitive biases are more relevant than these? Just for anyone.
Ryan.
Yeah. I was going to say, I have to think back to those. There definitely has been research on this. So I would say that sort of the responsibility, I think Allie spoke about this earlier, responsibility for harm often comes up with those sort of unacceptable or taboo thoughts, as well as sort of the checking behaviors that we see when individuals are concerned about being responsible for a fire or a burglary, things like that. With intolerance of uncertainty, honestly, it kind of cuts across most of the subtypes, I would say, but also those same two subtypes certainly involve a lot of uncertainty. But we also see intolerance of uncertainty with folks with contamination, for example. You might be uncertain, did I wash my hands enough to feel clean? The contamination subtype is also definitely associated with the kind of overestimation of threat. And I did, this is sort of a tangential comment, but I really liked one of the questions in the chat, which was sort of about how this relates to, let me see if I can find it.
It was the logic question. That was really cool.
Yeah, the logic question. Yes. So this is sort of a tangent, but I did want to comment on it. So this idea of, we know that, based on clinical experience, both those who have, oh, that's cool. Both those who have OCD, know this, as well as those of us that work with OCD, which is that you can't really logic your way out of OCD. Folks with OCD have been told by, all their loved ones, like, oh, for example, with contamination concerns, it's so unlikely that if you touch this toilet that you're going to, catch HIV, or it's so unlikely that this is going to be the one time you don't check the stove and your home is going to burn down. And in the past, we have tried to use cognitive strategies to kind of say, oh, well, what is the likelihood? Let's examine the evidence. But I think most of us know that that only gets us so far. So that, folks with OCD know that these things are incredibly unlikely to happen. And yet there's still the what if. So that's why I honestly stay away from any examining the evidence or what's the likelihood, or let's try to logic our way out of it. Cause I really don't think it gets us very far. And rather it's more about, okay, we know the likelihood is very low. How can we kind of tolerate or sit with that low likelihood in a way that all of us unfortunately have to do whenever we lock the door or turn off the stove or use a public restroom. So focusing more on tolerating the uncertainty, the distress, and the chance that something bad could happen. So that's sort of an aside. Hopefully that answered the question, but if not, feel free to comment back in the chat. But anyways, in terms of other subtypes, let's see, Allie, did I forget any? I'm sure I did. What other ones are coming to mind?
You mentioned most of those that came to my mind in terms of what we see cleaner evidence for.
We did a study. I'm going to share my screen. A few months ago, I shared my screen and people seem to really like that. So I'm going to attempt to do that now.
Believe in you, John.
Let's see here. Share screen. Aha. Okay. So this is from a study.
Wait, no, you're just bigger.
Oh, you can't see the.
There, got it.
There it is.
Okay, there we go. So this is a study that we did in 2010, so it's a little older. But we looked at, so the DOTS is the Dimensional Obsessive Compulsive Scale, and it has subscales that measure contamination, fears about responsibility for harm and the need to check, these unacceptable thoughts that we've talking about, we've been talking about, what if I harm someone, or unwanted sexual thought, and then the need for symmetry and exactness and perfection. And this is the Obsessive Beliefs Questionnaire, the subscale of responsibility, the tendency to feel responsible for things in a kind of hyper responsible way, and the overestimation of threat. So that cognitive bias was correlated not all that strongly with contamination, but pretty darn strongly with responsibility for harm. Once you see correlations up around 0.4, 0.5, 0.6 and above, it's pretty strong. The importance and need to control thoughts is this ICT, and that was most strongly associated with unacceptable thoughts. This is like thought action fusion over here. Perfectionism and the need for certainty, that was most strongly correlated with this symmetry aspect of OCD, the not just right OCD. Mm-hmm. And none of them were all that strongly associated with contamination. That's actually something that's been found in a number of different studies, maybe because contamination, this dimension of OCD, is kind of multifaceted. You have some people that worry about disgust, some people that worry about getting sick, some people that worry about getting other people sick. So just an example to kind of show you the kind of studies, and there have been lots of studies done like this, kind of showing similar stuff. So let me see. I stopped sharing.
Yeah.
Yep.
Back. Okay.
That's really fascinating. The contamination doesn't seem to align well. And then the responsibility for harm symptoms, all the cognitive biases seem to play some role.
You would think, but I think it's more about the way that we're measuring contamination. Contamination can be a lot of different things. Folks that have contamination OCD, they might present in different ways. And one day, just like we split out contamination and checking and unwanted thoughts, one day, 50 years from now, we might say, oh, there are different types of contamination OCD.
Do you have something to say, Ryan?
Yeah, I was just going to say, I think the other thing that complicates, so that paper by Mike Wheaton, he was using one of the gold standard measures of obsessive beliefs, the OBQ, or Obsessive Beliefs Questionnaire. But one thing that's challenging about that measure is that, for example, they lump perfectionism and certainty into one subscale. So I do wonder, like, I don't typically see perfectionism being as big of a factor in contamination, although certainly for some folks, they need to wash their hands perfectly. But I do think, I do wonder if we could separate out the perfectionism and certainty, if intolerance and uncertainty might have popped out a bit more. But yeah, it is a great paper.
Mm-hmm. Also, Amy has another question in the chat that I think is worth mentioning. At 1228, what is the difference between a bias and a distortion? Is there a difference?
Good question.
I'll be interested what other people say, because the first thing coming to mind to me is I think I think of them as the same, but maybe other people disagree and think of them in a more nuanced way than I do.
I was hesitating to speak because same. Yeah, I think we often use those words kind of interchangeably. Maybe distortion is sometimes also referring to like thinking errors, so like catastrophizing and that sort of thing. So maybe it's a broader term, but I think a cognitive bias would probably also fit under that umbrella.
Yeah, I would agree completely. And actually, so Amy Ellickson at 1216 said, so a cognitive bias is normal unless it's carried to an extreme. And the answer to that is absolutely. We all have cognitive biases. And for the most part, they don't really get in the way. It's just kind of the way that we interpret the world. But when we start to when it becomes extreme, it becomes more rigid, and when we have trouble recognizing it, and it comes up a lot, then it becomes something that does get in the way and can lead to anxiety and depression and anger and things like that. I like the way that we're talking about.
So as you can tell from the chat, a lot of the people who are watching have OCD. So I kind of want to shift focus now to treatment a little bit more. So we clearly have a pretty good handle. Well, I shouldn't say clearly. At least we have like some cognitive biases that we have a fancy name for, and we've done some studies on. How has this informed the treatment of OCD, that we can kind of pinpoint some cognitive mechanisms?
Jump in, guys.
Yeah. So I guess, when I originally learned exposure and response prevention, sort of the way that, we were doing ERP was to, teach individuals with OCD at the start of treatment about cognitive biases, about what they are, about how to identify them, and even to sort of self-monitor them. And, you can even do, cognitive therapy at the beginning to start to challenge those sorts of beliefs or to question them. Although increasingly, as I was sort of alluding to, I think that has only moved the needle so far. And so to be honest, now when I'm treating OCD, I sort of jump immediately to exposure therapy and don't necessarily introduce the cognitive biases at the beginning, but rather bring them up in the context of exposure. So I'll give a specific example. So let's say we were going to do an exposure. I'll do an importance and control of thoughts example. Let's say we were going to do an imaginal exposure where the person is writing out kind of about a worst case scenario that they're fearful of, that they would suddenly take a knife and stab a loved one with it, and never knowing for sure whether they would one day do that. What if they did do that? It would be the worst thing possible. And they're writing out this imaginal script about these things happening and then recording and listening to it. So rather than teaching someone about the importance and need to control thoughts up front, sort of in an intellectual way and talking about it then, I would do the imaginal exposure first. And then when sort of trying to bring together what was learned and what surprised you about the exposure, I would then say, wow, it actually, what did you learn? What surprised you? And were you actually able to do this? Was it, were you able to tolerate it better than you thought? Were you able to, even though you maybe originally had these beliefs about needing to control these thoughts, were you able to, were you willing to have these thoughts? And so almost using the exposure as a way to do cognitive therapy in a way, rather than doing the cognitive therapy first. So I just think it lands better. I think it makes a lot more sense to folks where they're having that cognitive change in the context of an exposure, rather than just talking about it before even getting into the meat of ERP. And
do you do that processing after kind of the anxiety had come down and the exposure session had finished, let's say?
Yeah, as the exposure is wrapping up. And sometimes the anxiety does come down, which is great. And sometimes it doesn't, which is great too, because then we learn to tolerate that level of anxiety. So sometimes the exposure is trying to indicate like, wow, I could sit here and do this imaginal exposure with my anxiety at a 70, and I tolerated it better than I thought. So either way, we're sort of tying it all together at the end of the session and what people learned and what surprised them about it.
And actually, to that point, there is a cognitive bias that we haven't talked about, which is called anxiety sensitivity.
Oh, yeah.
Which is the tendency to be afraid of your own anxiety. When my heart beats rapidly, I think I'm having a heart attack, as opposed to it's just my fight or flight response, right?
Mm-hmm.
And part of treatment and that's not specific to OCD at all. We see that across different anxiety-related disorders. Part of treatment for OCD, because we do know that it does tend to be elevated in OCD, with exposure is teaching people you can manage anxiety. Anxiety is safe.
Mm-hmm. Yeah,
Yeah,
I don't have too much to add because that was such a great description. But I think I would just underscore the utility of leaning behavioral with these sorts of interventions so that folks can learn through experience. Because if we think about how these cognitive biases might be functioning to maintain the disorder, particularly in terms of if you have these cognitive biases, it makes your obsessions really distressing and uncomfortable. Compulsions kind of function to bring that down and neutralize it. When we expose folks to what they're afraid of and we take away that ability to engage in the compulsion, they can learn firsthand that what they were afraid of happening might not happen and probably doesn't happen, and they can tolerate it better. So that lived experience you gain from going the behavioral route of exposure is super valuable and ends up changing those cognitive processes kind of indirectly.
You know, like I someone who's been through exposure therapy, it makes experiential sense, I guess, that exposure therapy is good. And it saved my life. But it is surprising to hear you guys kind of imply that like talking about these cognitive biases up front doesn't at least make the exposure process easier. Is there evidence that, discussing these in the beginning of treatment makes doing an exposure more tolerable, or is that just not something that's out there?
Good question, Kyle.
Great. In general, it seems like a lot of the research on ERP, whether you compare cognitive therapy, first versus no cognitive therapy, whether you add acceptance and commitment therapy to exposure or you don't, oftentimes when we do these kind of comparison studies, exposure wins regardless of how you do it. So, and I will say this is with the caveat though, when we're comparing group means across, large numbers of people, I think one thing that's very interesting, and I haven't seen any studies to this yet, but I'd be curious if others maybe are more up to date than I am, of how can we personalize ERP for individuals. So I bet if you go to the individual level rather than the group level, you might actually see that for individuals, there actually might be the benefit of doing cognitive therapy first to sort of tenderize cognitive beliefs before getting into exposure. Or for some people, maybe just doing straight exposure, like just get to it sooner, would help them get better faster. Some people really enjoy acceptance and commitment therapy or ACT metaphors. Other people sort of aren't into it. So I do think that there's a lot of our research is at the group level, and we don't really know at the individual level whether we can personalize ERP to maximize outcomes for specific people. But at least the research that I've seen on the group level, it sort of seems like whether you do cognitive therapy or not, whether you do ACT or not, it all kind of still works pretty well. So that'd be my answer.
I really want to hear from both Jon and Allie, though. It's very interesting.
I would totally echo what Ryan said. And I think that's such an interesting question for future research is, does the tailoring at the individual level make a difference? Because I think that's probably something therapists just kind of naturally do based on their work with the client and their sense of what that client might need to have therapy be useful or have the exposure happen, is you flex your approach to meet the patient where they're at. So I'm sure that some of that is happening just naturally, but I'm not aware of any research to suggest one way or another if like psychoed about cognitive biases at the beginning is generally helpful or not. So someone should study that if it hasn't been done.
These folks nailed it. I have nothing to add.
Okay. It still feels like counterintuitive to me, I suppose. Were cognitive biases did they kind of integrate into the OCD literature after ERP had already been worked out?
They did. So so ERP was worked out in the 40s and 50s, not specifically with OCD, but with fear and anxiety. And then in the 60s and 70s, folks started to apply it to OCD. Exposure and response prevention kind of came out of that in the 60s and 70s. The cognitive revolution in psychology was this idea that we should focus on more than just behavior, but organisms think, or human organisms think. We have a brain, and it's that thinking that leads to anxiety. Something happens, we interpret it a certain way, we see it as a threat, and that leads to feeling anxious. And so in the 80s and 90s, all of this research that we're talking about now with the different cognitive biases, cognitive distortions, that really blossomed in the 80s and 90s in the OCD area. It had been worked out in like social anxiety and depression and other disorders in the 70s and 80s, but folks didn't really understand OCD very well. They didn't understand obsessions very well till the 80s and 90s.
Yeah, and it's kind of interesting because the treatment has stayed pretty similar through all that time. It's exposure. But with the addition of this knowledge about how cognitive biases might be playing a role in OCD, those cognitive biases are absolutely treatment targets, and they play a huge role in how we conceptualize clients and think about treating them. It's just the way we do it is kind of similar. It's behavioral.
Yeah, it hasn't really changed.
Well, and as someone said, like, exposure just has a lot of firepower. There's nothing like that experience, right? Experience is the best teacher. So we can talk about it forever, and people were doing that for a long time. But there's nothing like getting in there and seeing for yourself and having that like Allie said, that lived experience of your own anxiety and seeing that it's there, and maybe it goes away over time, or maybe it doesn't go away as fast as you like, but you're able to manage it and it's not dangerous. And that corrects a lot of these cognitive biases without having to sit and talk about it.
And we spoke a little bit about how these cognitive biases kind of can cut through a lot of different diagnoses. Is this different if we look at like the treatment of depression, the treatment or of an eating disorder, where maybe talking up front about the cognitive biases may have more of an impact on treatment?
That's a really good question. I don't know if you guys want to jump in. I'll just say really quickly, a lot of like depression has depression treatment. Cognitive behavior therapy for depression involves something that's kind of similar to exposure. We call it behavioral activation. And it's basically like, we're going to put some fun things on your schedule and you're going to get out there and do them, even if you're feeling, bad, even if you're feeling depressed, and you're going to see that you can do these things, even if you're feeling unpleasant, and do the things that are important to you. We don't call it exposure, but in a way, it is exposure. It's experience. Mm-hmm. So, and certainly in the other anxiety disorders, social anxiety, PTSD, panic attacks, we do exposure therapy to change cognitions. Mm-hmm. I like to say exposure therapy is the best cognitive therapy that we have. A lot of people, the pure behaviorists get upset right at that because exposure therapy is a behavior therapy, but it changes cognition.
Yeah, and often in the treatment of other disorders, like other anxiety disorders or depression, even if you're kind of leaning cognitive and you're working with a client to test a particular belief or examine a particular belief, usually or oftentimes what therapists will do is they'll set up behavioral experiments to test that belief. So again, not exposure, but you're asking the patient to go out and do something that they're feeling a little unsure about to test a belief. And you have a debrief afterwards and you talk about how it went and what you learned. And through that process, you end up changing cognitive biases or dysfunctional beliefs. So there are definitely parallels across all of these treatment approaches, at least coming from a cognitive behavioral lens.
Yeah, I totally agree with both of those comments. And interestingly, I'd be curious what others on the panel think about this, but it seems like for me, the one anxiety disorder where I do start with cognitive techniques first is actually social anxiety, because I do feel like there are a lot of really specific cognitive biases that folks with social anxiety hold, like mind reading, like I know for sure what other people are thinking of me, personalization, like everyone's laughing, it must be about me. And so I have seen kind of teaching folks about those types of cognitive biases and monitoring them in one's day-to-day life actually start to move the needle in terms of social anxiety, because I think those often are things that folks with social anxiety don't realize that they're doing. And so shedding light on those I have seen be beneficial. So when I treat social anxiety, I do typically spend a session talking about cognitive biases, whereas I don't in OCD, just because I've seen OCD sort of hijack the cognitive restructuring in a way that, you know, it's like, but I still don't know for sure, even though we've tried to talk through the logic. So I tend to lean more behavioral with OCD.
Yeah, John and Allie, does that kind of square with your experiences?
Yeah, especially when you have that need for a guarantee of certainty, which I guess you don't see it as much in social anxiety, but you sure do see it in most of OCD. And so you got to be really careful about talking therapies with OCD, because the patients are often going to use I shouldn't say going to, but there's a high risk that they can turn that into a ritual.
So, I mean, I do want to get to Josh's question, but I want to follow up really quickly on what Ryan just said. This may be super amorphous and annoying to answer, but I'm going to ask it anyways. So if you, in your experience, Ryan, social anxiety seems to maybe respond to some more cognitive treatment at the offset, because people may not be aware of these biases that they're falling into. I mean, I still don't see why that logic wouldn't apply to OCD. Like, I was not aware when I started treatment that I may have been engaging in thought action fusion. So why, I suppose, do you think it might work better in social anxiety?
Yeah, I do think actually thought action fusion is a good example of one where people maybe don't realize that they're doing it. But I do think, you know, folks with OCD who even haven't been to exposure therapy, they probably know they struggle with uncertainty. They probably know they struggle with perfectionism. And so I don't think teaching folks about those necessarily does move the needle much in terms of helping them with exposure therapy, because folks will say like, well, of course I know I struggle with uncertainty, but like, now what do I do about it, or how do I tolerate it? So I do think thought action fusion is one that maybe people are less aware of. And so if I see folks kind of making statements like, well, having an unwanted thought is just as bad as doing it, I will point that out in the context of, ERP.
Well, and I think education is different than cognitive therapy. So it's one thing, as you're saying, Ryan, to point it out and educate people. Hey, this is a cognitive bias. Do you see where you're doing it? But then there's another thing. To kind of, now let's dispute that. Let's spend sessions and sessions trying to help you to see why, verbally talking about why that's illogical.
Yeah.
Okay. Yeah, I see. That's a helpful distinction to make. So, like, rather than spending sessions trying to combat these biases, like still doing the exposure, but as you go through the exposure, just making a mental note, like, hey, you just engaged in this bias. Let's keep that in the back of our head. Josh asked a really interesting question at 12:37. Is there any research into OCDers underestimating their own capability or perception? I think a lot of value in ERP is in helping people build confidence that they're able to handle uncertainty and anxiety in the pursuit of their values, rather than letting their anxiety, guilt, or shame direct their behavior.
That's a great question. And I'll jump in with the first thing that came to my mind is early on, there was this question of if maybe OCD was associated with memory deficits. So to go back to what John mentioned at the very beginning of the live stream about the difference between a deficit and a bias, deficit would be the hardware issue. There's something not working as intended cognitively. So the question was, is OCD associated with just poorer memory abilities? And is that why folks need to repeatedly go back and check if they turned the stove off or if they locked the door because they just can't remember? Turns out evidence for that is pretty poor, but what we do see a stronger signal for is that patients with OCD have less confidence in their memory. So they can remember just as well, but they doubt that their memory is right. And it's that doubt and that lack of confidence that ultimately is contributing to the need to engage in compulsions. So that's one area of just like lower confidence being a part of what's maintaining OCD symptoms.
Yeah. I was thinking that. Oh, go ahead, John.
No, I was just going to say, I remember reading that paper in grad school on memory confidence. And wow, the future of our field is great if you're familiar with all that stuff. This is awesome that you know about that.
Yeah, I was thinking of the same study as well. And I'll even tell patients about this too, because, from my memory of these original studies, there was kind of the group differences, individuals with OCD versus those without, or as well as the more people were instructed to go back and check, even if they didn't have OCD. So they would say, in one group without OCD, they would say, just, check the stove once, and then how confident are you that you turned it off? And then the other group, they would ask them to check again and again and again. And you can sort of replicate this finding where the more you check, the less confident you are in your memory, which just shows how checking behaviors can fuel these doubts and the lack of confidence in one's memory. So I tell patients about these studies, and I think that can be very helpful in terms of seeing how checking can maintain these doubts and maintain OCD.
That phenomenon is so interesting. That is
a really interesting phenomenon. I've never heard of that.
Yeah.
Adam Radomski, who's a researcher in Montreal, has replicated that time and time again, that the more you check, you actually become less confident.
Yeah.
Wow.
Yeah.
That's wild. I while we're talking about kind of like deficits as well, or the potential involvement of deficits, when I was reading a little bit before the stream, I saw something about maybe attentional deficits playing a role in OCD. And I wonder if you guys had a comment about that.
Yeah, sure. There's a lot to talk about with attentional deficits and attentional biases. So attentional biases, I'll start with that you would tend to think about as paying attention to particular stimuli over others. So in anxiety and related disorders, you tend to see a pretty clear pattern of a threat-related attentional bias. So they're vigilant to threats in the environment. They automatically orient there. Many researchers, as I'm sure you can imagine, wondered if you might be able to see this same pattern in OCD, because we have that inflated perception of threat as a cognitive bias that we've discussed. So maybe just what people are paying attention to might be playing a part of that. The picture is really muddy in OCD for that bias towards threat. And there's a lot of reasons that might be the case. And I think one that's really important to think about is how we've been talking about how the disorder is so heterogeneous. So we have different symptom dimensions and a lot of variability even within symptom dimensions. So like contamination OCD, we were talking about, one person might be really concerned about contracting a specific illness. Another person might be concerned about passing on an illness to someone else. So there's just a lot of variability in what is a threat. Consider that contamination world compared to thoughts about harm. What's a threat is super different from one patient to the next. So I think that heterogeneity makes it hard to study attentional biases in OCD. There does seem to be a little bit of a signal that when you look at more specific threats, you do see hypervigilance towards those specific threat types in OCD. So maybe that's contributing to the elevated perception of threat and associated compulsions that we've been talking about. So that's the bias part. A cognitive deficit or an attentional deficit would mean something's kind of funny with the attentional system. So there's also been a lot of research on attentional control in OCD, which is our ability to regulate our own attentional resources based on our current goals and desires. So I'm able to focus and shift my attention towards what I want to be attending to and inhibit distraction from things that I don't want to be attending to. We do see at the group level reductions in attentional control associated with OCD. We also see that in a lot of different disorders. So that's not super unique to OCD, but it might just be playing a part in patients having less volitional control over what they're paying attention to. And so attention might then be drawn more so towards threats or stimuli that might be related to one's obsessions and fuel that cycle.
Yeah, I totally agree. And I have two additional comments that aren't entirely related, but I guess the first comment is related to these attentional biases. And I agree with Allie that the literature gets very muddy. I think the other thing that can kind of muddy the literature in addition to heterogeneity and OCD is also like the time course that we measure attentional biases. So this sort of vigilance for threat we often see early on when you kind of have a quick stimulus and people will orient towards threat if they have a fear-based disorder like OCD. But then also the longer you measure attentional processes, then you start to see an avoidance of threat. So there's that initial orienting towards what's threatening, hypervigilance, and then the longer you measure it, people start to look away because, as we know, avoidance is a big part of OCD and other anxiety disorders. So depending on the time course that you're measuring attention, that can muddy the water as well. And then the other thing that I was thinking about in terms of attentional control that I find really interesting is that sometimes even when you don't find objective attentional differences, when you measure attentional control as a self-report measure, so just asking more about perceptions of your own ability to shift and sustain your attention, you'll see folks with anxiety and OCD saying, I have trouble with those things. I have trouble focusing. I have trouble shifting my attention, getting out of my head into the moment. And so I think that kind of difference between what we can measure objectively with our eye tracking tasks and our reaction time tasks and what people are perceiving is really interesting, because there's sort of this, even if perhaps in certain tasks, folks with OCD are performing objectively the same as someone without OCD, they're still perceiving it being more challenging. And so I think that just speaks to, how that's an important treatment target, as well as people's perceptions of their ability to control their attention.
Yeah, thank you for giving like a quick 5-minute summary of what seems like it's been a lot of literature and work. Jon, you also flagged another question that I want to get to before the time runs out.
Yeah, so Tom, at 12:43, I'm looking for the question now. Yes, how do these biases develop, right? We're talking about these ways of thinking, but how do we get there? Is it from childhood experiences? Is it from other stuff? I don't know. What do the panelists think?
I have a paper coming to mind about this, but I need to find it real quick. So Allie, if you have something off the tip of your tongue, you can go first.
I don't have a great understanding of like childhood experiences or developmental experiences that might lead to some of the more like belief patterns that we've been talking about. So I'm excited to hear what Ryan has to say. In terms of the attentional biases that we briefly touched on, we do seem to have evidence that there are a lot of situational variables that might dial up the volume on the extent to which your attention is drawn towards threats. So things like state anxiety. So if I feel anxious in the moment, it's much more likely that I'm going to display that attentional vigilance to threats. Or if thoughts related to my particular concern when it comes to OCD. So if I'm thinking about contamination or whatever my particular fear might be, that also might dial up the size of that attentional bias effect. Ryan, did you find your paper?
Yes. So I was a co-author on this paper. I was not the first author, but this was a paper by Noah Berman. I can try to share my screen. I've never done it in this system before, so I don't know if I'll do it correctly. Do I just click present?
Yeah, present, and then
you got this.
It's similar to Zoom, but not exactly the same.
Yeah. Okay.
You were thinking of a different. I was thinking of the paper, the Freeston, Rackman, Shafran.
Oh, interesting.
99. I mean, we don't. One of the while you're pulling that up, one of the interesting things about the cognitive behavioral model is that in the cognitive behavioral model, it's not trying to explain the cause of OCD like some of the biological models are. Cognitive behavioral models focus more on the maintenance. How come it doesn't go away? People with OCD, they, like we've been talking about, they often realize, yeah, I know this isn't likely to happen. But then why don't they just kind of recognize that and get over the problem? And it's those darn cognitive biases that get in the way. And then it's the compulsive rituals and avoidance strategies that reinforce those cognitive biases and prevent the person from, changing those biases on their own. But it is a great question. Tom's question is really important. How did we get there in the first place? Because if we could get rid of the cognitive biases, right, that would help us a lot with alleviating OCD. All right, here we go.
I got it. I had to change the permissions of my browser. So this was a paper that Noah Berman did while he was at Mass General Hospital with me. And so he was specifically looking at kind of intergenerational transmission of obsessive beliefs and symptoms. So he brought in both parents and their children in for the study. And so what I wanted to highlight was just sort of these results here that basically, he had this question, is it the type of thing where it's a one-to-one transmission? Like, so for example, where, someone holds beliefs about, thought action fusion, and then their child holds thought action fusion beliefs. And he found that that was not really the case. It's not like this one-to-one intergenerational transmission, but rather these general parental factors like religiosity, depression, anxiety, and stress kind of is a general vulnerability for then children developing obsessive beliefs and symptoms. So I thought that was an interesting paper just about how these things can pass on in families, but it's not, it's not so one-to-one.
That's cool stuff. That, and it's hard to do research on this, right? Because it's hard to do a controlled experiment for people's experiences and all of that. But some interesting hypotheses about experiences that people might have when they're coming of age or when they're younger, that might lead to these kinds of things. I just again, anecdotally working with clients, you'll sometimes get stories like, I had this dream that my grandfather passed away. And then like later that week, the grandfather passed away, and they started thinking, well, gee, so maybe my thoughts are really important. Maybe if I just hadn't had that dream, maybe he wouldn't have passed away. And of course, those two are completely unrelated. But then this guy started trying to control his thoughts and his dreams and all that. Who's to say that he wouldn't have developed OCD even if he wouldn't have had that experience? But it makes for an interesting hypothesis that we can have these experiences that we can learn. We can learn them from people that we look up to, parents, teachers. We are influenceable, right, when we're younger. My guess is that in combination with probably biological genetic factors, things like that, probably has a lot to do with who develops these cognitive biases and who doesn't.
Mm-hmm. I want to be conscious of everyone's time because we are at time. I have a bunch more questions. And a bunch more
guys back and do this again.
I have a bunch more questions that I want to ask, and I feel like we have a lot more to learn. At least I know I have a lot more to learn. But I want to thank my panelists for coming, and Jon for always being here. And thanks everyone for watching. The IOCDF has an online conference coming up that we can all look forward to. It's also a donor-supported nonprofit organization, so please consider making a donation at iocdf.org/donate if you can. Just thought I would plug that real quick. And thanks everyone for coming, and we'll see you next month.
Thank you.